Hey, I'm Dr. Sean Tierney, going to talk to you about elbow problems and how we look at it. We're doing musculoskeletal ultrasound diagnosis, sometimes musculoskeletal ultrasound guided procedures to work on your elbow. So when we work on the elbow, we're looking at some things that we didn't see maybe with the MRI, we didn't see maybe with the X-ray. We're adding information to that. So one of the first things that we're going to be able to assess in the elbow that's not assessed very well in those other imaging is the nerves. So when I think about the elbow, I think about nerves almost as much as I think about structure, right? So I'm going to look at the elbow, I'm going to look for swelling in the elbow, I'm going to look for swelling in the joint, I'm going to look for arthritis in the joint, I'm going to look for instability. Now instability is one thing that I can see in the elbow it's not going to show up on the MRI because an MRI is a static picture. An ultrasound I can move and see where things come apart. Is the radio ulnar joint unstable? Is the radiohumeral joint unstable? Is there a fusion? And then with the elbow, significantly, I'm always going to expect some kind of a nerve issue because it's surrounded by nerves. I have the superficial and deep radial nerves splitting around the elbow. I have a little area where the nerve can be impinged at the elbow or above the elbow at the spiral groove. Something about the radial nerve is to come down to the back of the hand. It's going to be half of this ring finger, but not the other half. That's going to be the back of the hand, and that's going to be the radial nerve. The median nerve is going to be the same thing on the front, half of this ring finger, and that median nerve is going to be more on the inside of the elbow, right, kind of outside of the right medial to or to the inside of the bicep tendon, and that median nerve can get impinged, and the pronator tunnel can be impinged around the joint, and when you have inflammation in the joint, not uncommon. Now, if there's inflammation and swelling in the joint, my biggest concern oftentimes is going to be the ulnar nerve. So the ulnar nerve is going to be on that little funny bone area on the back inside of the joint, between two little notches. Sometimes you get a little popping, the nerve will pop out of place. That nerve can cause you to have numbness in the hand on both sides, the front and the back of the hand, covering half of the ring finger. So I'm thinking of, is there a median nerve problem, a radial nerve problem, or an ulnar nerve problem originating from the elbow? And I'm looking at the structures of the elbow. Do you have a extensor tendon, lateral epicondyle tendon, or collateral ligament injury? I'm thinking about tricep tendon, I'm thinking about the bicep tendon, I'm thinking about your anterior medial ulnar collateral ligament, I'm thinking about your medial epicondyle. And what we're finding is, if you have a problem on the outside of the elbow, there's probably some nerves involved, but it's a good chance it's a tendon involved. On the inside of the elbow, there's probably a nerve involved, and there's probably a good chance that the tendon is not involved. A ligament could be involved, but it's kind of rare to see medial epicondylitis. I would say for every one medial epicondyle, I see 100 ulnar nerve problems that people mistake for medial epicondylitis. So we're looking at the elbow in a little bit more comprehensive way because we're thinking about the nerves, we're pushing on the nerves, and now we have the ability to guide a needle with better than 1/10 of a millimeter accuracy to an area and make it numb, or else do a hydrodissection where we push the connective tissue off the nerve to free the nerve to help the nerve feel better. So we have those two techniques. So if I say, I think that the problem is this nerve that's impinged here, and we hydrodissect that, and I can, within 5 minutes, I can say, do you feel better or not? I was right or I was wrong. So we get this constant feedback of, are we right or are we wrong? Because there's an immediate change. I can put a little local anesthetic on that tendon and know if that tendon was a pain generator or not. So I can get this really accurate diagnosis, not only from the imaging, not only from pushing, but also from this procedure. So once I know, okay, these are your injuries, now we can work together to make a decision of what we do for those injuries. Some of these injuries may require surgery, and if that's the case, we can get you there quickly. We'll rapidly get you to a good person. A lot of these injuries require hydrodissection or just putting something into this injured structure, like a tendon, ligament, or joint, to stimulate that to heal. So there's a menu of things to do that. But we have the capacity to know what your problem is at a higher level of accuracy, and then more predictably get you better. So a lot of times what happens in medicine and in healthcare is that you look at the elbow as a structural problem, and the nerves don't get addressed. Because the nerves are a big issue in the elbow, I'm gonna say 50%, then the chances of you missing the relief from the surgery or whatever procedure therapy you have is high, because the nerves weren't addressed. So now that we can address the nerve, we bring your likelihood of getting rid of your problem statistically much higher. So the elbow with ultrasound, we're also looking at the tricep tendon, everything around the elbow with a tenth of a millimeter accuracy. And we also think of the elbow as an extension, in some ways, of the wrist. So that's the next thing I'm going to talk about, is the wrist and the hand.